Welcome, and thank you for joining our first virtual lung cancer community event. My name is Stephanie Wells from Mike and Steph in the Morning on B104. This event is held every November in honor of Lung Cancer Awareness Month. And although things look a little bit different this year, our program will be just as informative as it always is. For some general housekeeping rules, I want to let you know that all participants have been muted with their video cameras off upon entry as a way of eliminating feedback and distractions throughout the program. We greatly encourage you to ask questions this evening. So if you have a question, you can use the chat feature located on the right side of your screen. Now you will see an option there to send your question to all panelists, and this way they will be sent only to myself and the physicians participating tonight. And that will ensure confidentiality from other attendees. Again, you want to choose all panelists on the chat screen. Now, you can address your questions to a specific doctor if you wish, or you can ask a general question and we'll make sure to direct your question correctly. This program will be recorded and will be made available to watch again at a later time. And finally, when you exit the event, at the conclusion of the program, a survey will pop up. And if you could please take a few minutes to complete it, we would greatly appreciate it. We value your feedback, and we always use it when planning future events. I'd like to now introduce to you some of our physicians from Lehigh Valley Cancer Institute, LVPG, and LVH who will be participating this evening, including Dr. Elliot Friedman, medical oncologist for LVH, Hematology Oncology. Also, Andrea Rivera Rodriguez, certified registered nurse practitioner for LVPG, pulmonary and critical care medicine, and Lehigh Valley Cancer Institute's lung health program. Dr. Robert Kruklidis, Vice President of Transformation and Pulmonologist at LVPG Pulmonary and Critical Care Medicine. Dr. Sean Quinlan Davidson, Radiation Oncologist for Allentown Radiation Oncology Associates at Pocono. And Dr. Richard Chang, Thoracic Surgical Oncologist for LVH Cardiac and Thoracic Surgery and Chief for the Section of Thoracic Surgery. And now I'd like to welcome Dr. Friedman. Welcome.
Thank you very much, Stephanie. It is our pleasure to be here. Last year we got snowed out. This year the weather is beautiful, but we have other minor impediments, but we're happy to be joining you for what we hope will be a great program. It's my pleasure to introduce our two main speakers. Andrea Rivera Rodriguez is a nurse practitioner that joined us a little over a year ago to lead lung health and lung cancer screening. We've had a very robust lung cancer screening program for over a decade and hit our highest numbers ever before this recent surge in COVID. She will be talking about our lung cancer screening program. Dr. Rob Kruklidis will be our other speaker tonight. I know Rob for well over a decade. He has really brought amazing technology to help take care of our lung cancer patients diagnostically and therapeutically. And he will be speaking on the latest technology that we're bringing to the network to help diagnose our patients with lung cancer. So with no further ado, I will introduce Andrea.
Thank you, Dr. Freeman and Stephanie. My name is Andrea Rivera Rodriguez. I'm a nurse practitioner with the Pulmonary Department and the Cancer Institute. I'm a navigator and the manager of the lung cancer screening program. As they said, I'm going to be talking about the importance of lung cancer screening and our lung cancer screening program. Lung cancer is the second most common cancer in both men and women. It mainly occurs in our older population, patients from 65 and older. Their average age of diagnosis is 70 years old. And unfortunately, lung cancer is the leading cause of cancer death in the United States. Lung cancer causes more death than colon, prostate, and breast cancer combined. There are several risk factors for lung cancer, including smoking. As a lot of people know, this is the main risk factor for lung cancer. Other risk factors include secondhand smoking, exposures to radon, asbestos, and other cancer-causing agents. There are some risk factors that you cannot change, which is your personal history and your family history of lung cancer and air pollution. Next slide. Yeah. We have been seeing a decline in lung cancer death rates since the 1990s. There's been a 50% decline in lung cancer death rates and a 16% decline in women. This is attributed to more people quitting smoking and less people starting to smoke. We have some good news is that we are seeing less numbers of lung cancer and less death rates in our patients with lung cancer. And this is, as I said, because more people are quitting smoking, and also there's more advances in early detection and treatment. When I say advances in early detection, now we have more cancer screenings available. Screening is a type of test that is done to find specific type of cancer before there's any signs or symptoms. An example will be mammography, colonoscopy, and lung cancer screenings that are done with low-dose CT scans. Why should our patients get screened for lung cancer? Because, as I said, lung cancer is the most common cause of cancer death in the United States, both in men and women. Most cases are diagnosed at a late stage, and if you get screened for lung cancer, there's a better prognosis if the lung cancer is caught at an early stage. A very important study was published in the New England Journal of Medicine that wanted to determine which test was better for lung cancer screening. They screened 53,000 patients that were between 55 to 74 years old. All these patients had more than 30-pack-year history of smoking. And if they were former smokers, they were between, they quit within 15 years. What they tried to do was find which modality was better, annual low-dose CT versus an annual chest X-ray. And what they found was the annual low-dose CT was able to show lower the mortality on lung cancer screen and lung cancer patients by 20%. This study also showed that low-dose CT was able to actually find more lung cancers in patients at an early stage versus the chest X-ray. And as I said, it was able to show that there was a lower mortality in patients that were actually screened with low-dose CT. I keep saying low-dose CT. What is this? It's like a CAT scan that everyone knows, but it has a low dose of radiation, so it's safer to do yearly. As you can see in this picture, it's not an enclosed machine like an MRI. It only takes around 15 minutes, so it's something easy to do. The goal of the low-dose CT is to find early stages of lung cancer. Like in this image, we can see this white area that is pointed here will be what we call a lung nodule. And the criteria for lung cancer screening are patients that are between 55 and 70 years old, or 55 to 80 years old in private insurance. They're current smokers, or they quit within the past 15 years. And they have to have at least a 30-pack-year history. The way to calculate that is you multiply how many packs per day you smoke and by how many years. For example, you smoke 2 packs per day for 15 years, that will give you a 30-pack-year history, or you've been smoking 1 pack per day for 30 years, that will also give you a 30-pack-year history. It is important to know what really happens when you get screened for lung cancer. So if you have you meet criteria for a low-dose CT, you will go see your healthcare provider, like your primary care physician, or you can come to our lung cancer screening program, and you do a shared decision-making visit. What that is visit where you're able to discuss with your provider what are the risks and benefits or of doing a lung cancer screening. Then you will actually go and do the low dose CT where within the CT scan machine. Um, our radiologists read our your low dose CT and give us a report. Lung cancer screening are divided between lung RETs 1, 2, 3, or 4. What that means is a lung RET 1 is a patient that has a low dose CT that is negative. It's everything is normal, and you require lung cancer screening within a year. A lung RET 2, it's a patient that has something that's most likely benign, and that will also require lung cancer screening within a year. And lung RET 3 is that there's something on your scan that is most likely benign, but we would like a closer follow-up, so you get a lung cancer screening within 3 or 6 months. And lung RET 4 is that there's something in your scan that will require further testing. So at Lehigh Valley, we have a thoracic multidisciplinary team. We meet every Wednesday, and every lung RET 4, we discuss and give a recommendation for further testing so you get an accurate test after your lung cancer screening. In our program, we have navigators that would actually expedite your diagnostic testing if that's needed. We also make sure that all of our lung cancer screening patients follow up with their low dose CT. So if you need one in 3 or 6 months, we'll make sure that you are scheduled for those. If not, we'll talk to your provider and you to make sure that those are completed. We're also your contact patient for any questions that you might have. And we have nurse navigators in all of our campuses, Cedar Crest, Schuylkill, Hazleton, and Muhlenberg. Our screening in the Lehigh Valley has been begun in 2007. We offer out-of-pocket financial support, and also very important, no one is turned down for their inability to pay. And we make sure that if you have a lung cancer screen, that it's billed correctly for your insurance to cover it. And Medicare Part B now covers the cost of annual lung cancer screenings. Our lung cancer screening program has actually seen an increase in stage 1 lung cancers, which is good. We're being able to cut lung cancer early for patients to have a better prognosis. And we also have seen a decrease in stage 4 lung cancer with our screening program. Here at Lehigh Valley, we offer great advances in treatments. Like for biopsy, we have a new machine, which is a robotic bronchoscopy that Dr. Kuklides is going to actually explain and talk about. We also offer minimally invasive thoracic surgery with Dr. Shang. We offer robotic assisted lung surgery with the Da Vinci system, which it's better for patients, offering a better recovery after surgery. We also have leading edge cancer therapies with clinical trials, immunotherapy, and we're partnered with Memorial Sloan Kettering. We also have state-of-the-art radiation therapy. We have other resources for our patients, for lung cancer screening patients or patients that are newly diagnosed with lung cancer. We have, as I mentioned, the thoracic multidisciplinary clinic where experts in lung cancer meet every Wednesday, and your lung cancer patients are able to, in one visit, see an oncologist, which is Dr. Freeman, an interventional pulmonologist that includes Dr. Kuklides, radiation oncologist, and our thoracic surgeon, Dr. Sheng. We also have other lung health program navigators that will help you from lung cancer screening all the way to diagnosis. And we have our thoracic nurse navigator, which are very important in our team. They guide our lung cancer patients through treatment and connect them with other Cancer Institute services that needed. And we also have a thoracic tumor board that lung cancer specialists meet and review all active cases and develop individualized treatment plans. And we also offer, which is very important, our tobacco treatment program where patients can meet with our counselors over the phone or face-to-face. They also offer different type of treatments that you might need, and you can call to the number in the screen if you are interested in the program. And that's all. If anyone has any questions, they can write them here in the chat. Here is also my email if anyone would like to contact me as well. Thank you. Now we're going to follow up with Dr. Kouklides, which is going to talk about robotic bronchoscopy.
Good evening, everyone. Great to be with you. I'm Rob Kouklides. I'm one of the pulmonary or lung doctors at Lehigh Valley, and I am I'm our network's lead bronchoscopist. So, bronchoscopy is a minimally or non-invasive procedure where we manipulate a fiber optic scope into a patient's lung. Now, we certainly do that with our anesthesia colleagues. Patients are asleep for this procedure, but we use the bronchoscope as a tool to. Very often, we want to get samples from the lung, try to figure out if a patient may have pneumonia, for example, or maybe try to figure out if they have a cancer. So often, we're trying to obtain specimens from the lung, but occasionally we'll use the bronchoscope to treat people. For example, some patients have tumors in their airways, and we'll use a laser, for example, to try to remove that tumor. What I'm going to talk to you about tonight is one of our latest advances, our robotic bronchoscopy program. So next slide, please. So I just want to start by really kind of highlighting and reiterating a couple of the points that Andrea made. She said this, but this is really important. There are more people who die in the United States every year from lung cancer than the number of patients who die from breast, prostate, and colon combined. 154,000 people die in the United States from lung cancer. So this is a big problem, and this is really the basis for all of our efforts in terms of both preventing, as Andrea mentioned, best way to prevent lung cancer is to either not smoke or stop smoking and screen for lung cancer. Next slide, please. So here's why screening is so important. It turns out that if we find lung cancer early, which is what screening has been proven to do, allow us to find lung cancer early lung cancer, stage 1 lung cancer, we have a real good chance of curing that. And in contrast, when lung cancer is found late, at more advanced stages, for example, stage 4, it's really difficult. Our oncologists have made tremendous improvements over the last several years. They're really doing some great things with targeted therapy, immunotherapy, and we've really come a long way. But nonetheless, it is so much better if you need to have lung cancer, you want to find it early, because that really is a much more curable disease. Next slide. So Andrea walked you through the process of a lung cancer screening. You get your CAT scan, and after the CAT scan's performed, she mentioned our radiologists will read them. And many patients, they have no sign of cancer, and that's really what we want. And you then just would continue with the annual screening as she described. However, there are some patients who we find what the radiologist would call a spot, and we call those spots nodules, a lung nodule. And so that's kind of what we're looking for. But if you have a nodule on your lung, it does not mean that you definitely have cancer. There are many causes of lung nodules. In fact, most lung nodules probably are not cancerous. Next slide. So people ask me, well, I've got this spot, or you're telling me I've got a lung nodule. If it's not cancer, what is it? And I think that this slide kind of addresses it. There, certainly infections can cause nodules and inflammation. Certainly cancers cause lung nodules as well. And there are benign or non-cancerous lung nodules. So that's kind of that's kind of my job. The patients often will come to my office when they've been found to have a lung nodule, either through lung cancer screening or, however they're found to have it. They make their way to my office. And, sometimes when we look at these nodules, we just know for certain that these are going to be cancerous, and we certainly treat those aggressively like a cancer. And some of the nodules we look at, and we're as sure as we can be that they're nothing to worry about. And in those patients, what we'll often do is just follow them with CAT scans, but they probably don't need any real further intervention. But having said that, there is a kind of a large number of people who are kind of in the middle. They have what we call indeterminate nodules. And what that means is when we think about it, we kind of ask ourselves, geez, do we think this is a cancer? Well, I wouldn't be surprised if it was a cancer, but I wouldn't be surprised if it wasn't. And so those are often the tricky cases. What do we do if it might be a cancer, but it might not? And in those cases, we really think that it would be helpful often to be able to get an accurate biopsy so we could determine, is this definitely cancer or not? Next slide. So there are several ways to go about biopsying the lung. The first way was really developed back in the 1860s, and that's surgery. To have to biopsy a lesion with surgery, that's kind of a big deal. That's invasive. We try not to do that. In most cases, that really is not necessary. The next advance kind of came in the 1940s, and that's a procedure called transthoracic needle aspiration. We kind of call that today, we call that a CT guided biopsy. That's a procedure our radiologists do. You kind of come into the hospital, we put you in the CAT scanner, the radiologists numb up your skin, and they put a small needle generally between the ribs and directly into the spot. And well, that is certainly a good way to accurately biopsy a spot on the lung or a nodule. There are, depending on the size and the location, there's a real risk of some complications with that procedure. And I think the other thing that's important to note is the CT guided biopsy really does not have the ability to biopsy or assess lymph nodes. And I think many people know that when we're thinking about cancer, it's very important to know, has the cancer spread to the lymph nodes? So that's not something we can assess with this CAT scan guided biopsy. Next slide. So then that takes us to bronchoscopy, and fiber optic bronchoscopy was first developed in the late 1960s. And this is a procedure that really every hospital in our country performs. But the standard bronchoscopy really, it allows us to manipulate a camera, to guide a camera and a scope down into the patient's lungs. It can only get about a third of the way out in the lungs. And so most of these lung nodules we never see. And that really means that in many cases, we're just kind of trying to guess where to put our biopsy tools. And that, it doesn't help to get a biopsy if you don't biopsy the right spot. So that's standard bronchoscopy. That's what most hospitals in the United States do. Navigational bronchoscopy was the next advance. That came in the early 2000s, and that was essentially putting a GPS system on the end of the bronchoscope. And that was definitely an advance. It just really hasn't proven to be as effective as many of us had hoped in terms of really accurately biopsying the spots that we're talking about, or the lung nodules. Next slide. So that takes us to robotic bronchoscopy, and that's what I'm here to talk to you about today. Robotic bronchoscopy is kind of a brand new procedure. This is really first released and approved in 2018, and many of us really believe that this is going to be a game changer. This is really going to allow us to much more reliably and accurately biopsy these lesions, so we can tell the patients, hey, this is a lung cancer or it's not. Next slide. So this is what it looks like from my perspective. On the right-hand part of the slide, you see the CAT scans, and there's a nodule on this particular CAT scan, and we feed that information into our computers that go along with the robotic system, and that kind of shows the middle panel. That's what I'm looking at when I'm doing the procedure. So the computer has highlighted the lung nodule or the spot on the lung in gold, and it kind of looks like that iceberg on the screen. And you can see there's kind of a round structure right in front of that lung nodule, and that is representing where the bronchoscope is. And so you can see we're right directly in front of this, and we're about ready to run into it. And on the bottom of the middle panels, you see that kind of that green line. That is representing the biopsy tools that we'll use, and those tools will. It's telling me when it's green, I'm dead on. The biopsy tools are going to go right into the target. So that's what we want to see. On the left-hand part of the screen, that's the live image that we're watching during the procedure. And what I can see, I do this every day. You can see right in front of the camera is the lung nodule. And in the upper left-hand portion of that image, there's that silver structure. That's my biopsy tool coming right out directly into the target. So that's what robotic bronchoscopy is allowing us to do. And this is, again, something that we've never been able to do before. And you really need this system and the expertise in order to have this degree of accuracy and reliability. Next slide. So this is the team, and here we're in the midst of a procedure. I guess what I would like to end with is just simply to say that we're here for you. We hope you never need us, but if you do, we're here for you. The best way to find out if you do need someone like me and my team is to get your lung cancer screening tests. So certainly speak to your physicians about that. That's all I have. I'll turn it back to Steph.
Thank you so much, Andrea and Dr. Kruklidis, for sharing the valuable information. Here's the point at which you have an opportunity to ask questions. We're going to move forward to that second half of our program for the panel Q&A. Dr. Friedman, Andrea, and Dr. Kruklidis will now be joined by Dr. Quinlan Davidson and Dr. Chang to answer any and all of the questions you may have regarding lung cancer and lung health. And as I said earlier, you want to use that chat box that's on the right-hand side of your screen to send a question. And also you want to make sure you're sending that question to all panelists, and we will do our best to answer as many questions as we can. I'm going to start one off. The first question that we have is, if I don't smoke and I'm under the age of 55, but want to have a lung screening because I've been exposed to radon, will the screening be covered by insurance? Who would like to take that one? Dr. Friedman, I think you're on mute.
Okay, I'll take a crack and then have everybody else join in. The criteria were set up with the National Lung Cancer Screening that Andrea addressed in her talk. And that set up very strict criteria because the folks that ran that study wanted to make sure that they picked the right population to enable this test to be sanctioned for screening. In order for lung cancer, for any cancer screening test to be sanctioned, it must reduce lung cancer death by 20%. So that's why colonoscopy and pap smears and mammography and now lung cancer screening are all approved screening tests for lung cancer. Now that we have the criteria set, there are efforts around to start to broaden those criteria. And that includes radon exposure, secondhand smoke, asbestos, and younger people. We see people in their 40s who unfortunately have smoked 30 pack years. They smoke 2 packs a day from the time they're 10. So they're looking to broaden the the criteria to have insurance pay for lung cancer screening, but I'm not sure right now that it's there, and you might have to pay for it out of pocket. So I'll open that up for if anybody else has any thoughts.
Elliot, let me just add one important comment to that. So radon is a gas, and radon has been associated with the development of lung cancer. So, Andrea pointed out, number one cause of lung cancer is tobacco use, smoking. So that's why we say don't smoke. But radon is a cause of lung cancer, and it is relatively prevalent here in our area. So if you have not had your basements checked, I would encourage people. It's a very cheap test. It's a relatively inexpensive solution. If you have high levels of radon in your home, you really ought to have it remediated.
Very good. Thank you. Melanie coming in with a question regarding screening. I'm 48 and smoked for 20 years, but more than 15 years ago. My mom is currently being diagnosed with lung cancer. Should I be screened? Is there a genetic factor? She was a smoker as well.
Sean, you want to try that? Sean Quinlan Davidson has really developed a very robust screening program up at our Pocono facility. He's been doing it for many years. He's one of our leading radiation oncologists. I'll let you take a crack at it.
Yeah, so thank you. Good question. I'm happy to hear that you're aware and concerned. I'm sorry to hear about your mother. So, that's a good question. It's a particular scenario, but again, I think I'd have to go back to what Elliot was saying, or Dr. Friedman, is that there are certain criteria that patients need to meet to optimize the use of the low dose screening CT. And there are certainly, we're more aware of genetics and their involvement in the development of lung malignancies. So that's a consideration for your mother and the physicians who are assessing her about if there's potentially any mutations or other genetic issues that may tie in with her lung cancer. So I think for the moment, though, you don't meet the criteria for the lung screening program, although I do understand your concern given your mother and also your history of smoking.
Thank you for that.
As I said, they are looking for new criteria and to expand the criteria. So hopefully that will be coming in the near future.
Yeah, this is, I do agree that you have to be aware of the changing environment of criteria for lung cancer screening. And a lot of different institutions are looking at secondary levels of criteria for lung cancer screening. So it's in the works because, as Dr. Friedman had mentioned, the initial criteria is based on the studies. Having said that, I do think you probably should be screened at one point in time. It's kind of working around the insurances. It's trying to work around what is considered acceptable from an insurance standpoint. And the criteria, again, it's a changing, level in terms of how we're deciding who should be screened. And especially other people, for example, between the ages of 50 to 55, who have high risk candidates who are smokers or ex-smokers, who have family members who do have a cancer history, that fits into the secondary criteria. And so there's a lot of things that are in the works as we speak. So it's really hard to give you sort of hard and fast recommendations, especially when we're sort of constricted by that study, and then insurances usually base all the recommendations based on that study. So I think it's a moving target, and it will change over time.
Hey, Rich, it looks like the next question is for you too. So it says, as doctors are using minimally invasive tools more often, how confident do you feel that physicians will be able to switch to surgery in case of unforeseen events?
I'm not sure what clear on the question in terms of can they be a candidate for minimally invasive surgery, or they have to be switched over?
No, I think the question is, in case of a complication, how quickly can you go from a robotic to an open procedure? That's how I read it.
So when we do minimally invasive surgery, it's all set up as if we're going to do an open procedure. And then when we do the minimally invasive robotic lung surgery, we dock all the ports in for a robotic minimally invasive procedure. And safety is always the number one priority. So we never take any chances for any potential complications. So we set it up as if we can do it open as well. So the conversion is very quick, should there be any complications. And so the studies that have been shown comparing robotic surgery versus the standard routine open surgery, there's no difference in complication rate in terms of, say, mortality or any severe complication rate attributed to minimally invasive approach. All surgeons, including myself, we all consider ourselves doctors first, and then surgeons second. And then minimally invasive surgery is definitely an asset. It definitely for recovery, less blood loss, less pain, but it's more an advantage, not sort of a criteria. We always make sure that we do things safely. So in terms of conversion, it's very quick.
I would just quickly add that the same thing with this robotic bronchoscopy. It literally takes seconds to remove the robot and put in a conventional bronchoscope. So that it's a very safe procedure, very, very infrequent complications, but it really just takes us literally less than 30 seconds to switch.
We have another question coming in asking, is chemotherapy always involved in treatment for lung cancer, or are there other forms of treatment?
I'll take that one. So chemotherapy is a very important tool in treating lung cancer, but is not necessary in every instance. We know that if we find lung cancers in their earliest stage, which is stage 1, and or even early stage 2 lesions, where the tumor is under 4 centimeters and there are no lymph nodes involved, there is no additional therapy other than the surgery that can be performed. For more advanced stages of lung cancer, chemotherapy is used. So if you have a tumor that's removed, if Dr. Chang does surgery and takes out a tumor, and there's lymph node involvement, or if the tumor is more than 4 centimeters, then we usually recommend a 3-month course of chemotherapy. And we know that that can increase the cure rate and decrease the risk of recurrence. As tumors get bigger, they have the tendency to send out small satellites. So larger tumors are likely to have more microscopic disease somewhere in the body when they're removed. We can't detect it on PET scan or MRI or CAT scan, but they could be there and over time would grow. So we know that there are criteria to give chemotherapy following surgery. We are looking at the possibility of using chemotherapy or even immunotherapy prior to surgery to decrease the risk of these lesions before they even get operated on. So immunotherapy is being used as well. As we get to more advanced cases of cancer, stage 3, stage 4, clearly chemotherapy, immunotherapy, along with, in partnership with radiation therapy, or as a single modality, are being used. There are certain instances where we are using immunotherapy as opposed to chemotherapy or instead of chemotherapy. And then we have a whole new world of what we call targeted therapy, where there could be genetic changes within the cancer, and we have drugs that target those specific genetic changes and have a very high rate of success with a very limited toxicity. So chemotherapy is not always used. We have other techniques, and it's not used in every case, especially when they're found early. All the more reason to get a CAT scan screen so that you can find things in the earliest, and it's the most simplest to take care of and potentially cure.
I actually had a question for myself. You hear a lot about the term cancer metastasizing, moving into other parts of the body. I'm more familiar with that idea as it relates to breast cancer. But what can you tell us about lung cancer and the potential of it metastasizing, entering other parts of the body?
Sure. Well, we have 4 stages of lung cancer. Stage 1 is a tumor without any lymph node or other involvement. Stage 2 is involving certain lymph nodes. Stage 3 is involving more distant lymph nodes. And stage 4 is where it has spread or metastasized to other places of the body. So unfortunately, a majority of cases are still found in stage 4. And that's when it is not really curable. You know, with newer, and that's where it really requires chemotherapy or immunotherapy or targeted therapy, radiation, sometimes even surgery. But it is less likely to be cured when it's already stage 4, which means metastasized away from the original tumor to the other lung, to the bone, to the brain, to the liver, to the adrenal glands. So we like to catch it before that. Now I just put in a word, and I will reiterate one of Andrea's slides, which is very important. That we just finished looking at our 2018 data. We're going to start looking at 2019 data. But in the 3 years between 2015 and 2018, where our screening program took off, we reduced stage 4. That means metastatic incurable lung cancer decreased by 8%, which is huge in 3 years. And that's the whole idea, to catch it before you need me. I'm very happy when I can tell a patient that they don't need my services.
Very good, Dr.
Maybe
Elliott.
one of the points that we should just emphasize is that early stage lung cancer, most patients have no symptoms. And so that's the problem. With time, if you have a tumor and it's just growing and growing, eventually it will spread or metastasize. And that's what we don't want. And so Dr. Friedman's point is, by screening people, we are able to find the cancer when it's early and much more treatable. And that's why we're so proud of our lung cancer screening program and what we've done.
Dr. Kruklitis, I'm going to let you take this next question about the robotic versus navigational bronchoscopy, because I feel like I'm going to mess up that word more than once.
Yeah, great. So listen, absolutely, robotic bronchoscopy should, starting today, be replacing navigational bronchoscopy. You see, one of the things that maybe I didn't say clearly is robotic bronchoscopy is really combining several technologies, including navigational bronchoscopy. So a robotic bronchoscopy is a navigational, it's using navigational technology and other technology, optical pattern recognition, plus the robot allows us to go much, much further into the lung than we've ever been able to go before. The other, I guess, point that I should have made with bronchoscopy is I had mentioned that the CT-guided biopsy does not allow us to biopsy the lymph nodes. We can biopsy lymph nodes during the bronchoscopy. So the same procedure, not only can we try to biopsy the nodule, but we can also biopsy any concerning lymph nodes. And as Dr. Friedman had just pointed out, it's so important to know, has cancer spread to those lymph nodes so that we can accurately determine what stage a patient's cancer is, and that's the best way to get them the right treatment.
Okay, we have a question here. Is there usually a clinical trial available for lung cancer at any given time? What does that process look like?
This is a good time to shout out to Dr. Suresh Nair, who has worked very diligently in developing our clinical trials research program. We have a wide array of clinical trials that come from a number of sources. Many of them come directly from pharma, from the pharmaceutical companies. Some of them come from what are called cooperative groups, which are large consortiums of cancer centers around the country. And some of them come from single institutions. We have an association with Memorial Sloan Kettering, and they are really cutting edge at developing clinical trials for unusual forms of cancer, not only lung cancer, but others. and we have an expedited pathway to get those folks to Sloan Kettering, either for video or for virtual or other visits in person if people want to trek into Manhattan. We have good connections with all of the lung cancer specialists. When I see a patient who I think is eligible for clinical trial, I will email Greg Riley, who's the head of the clinical trials at Sloan Kettering. He'll generally email me back within a half hour with possibilities. So we have a broad array of clinical trials, and they're used at different times. For early stage lung cancer right now, we do not have anything. There's no reason because they get operated on, and hopefully it's one and done. For more advanced stages of lung cancer, if they're larger but still resectable, we do have clinical trials looking at postoperative chemotherapy or targeted therapy, preoperative immunotherapy. For stage 3, we have the ability to add other medications to disease, but our main push right now is looking at stage 4 disease. When patients have stage 4 metastatic lung cancer, they can get treated with chemo, as I mentioned, or immunotherapy, or targeted therapy. But once they've broken through those initial courses of therapy, what we can use is sometimes discoverable through a clinical trial. And we have a broad array of clinical trials for these patients with drugs that aren't necessarily used for lung cancer, but may work for breast cancer, but you find the same characteristics in your lung cancer and can try that drug and see if it works. So yes. And the other thing I just want to mention is clinical trials close quickly and open quickly. So it's kind of a moving target because they're set up to reach a certain number of patients to participate. So because we have a clinical trial now, it may not be available to us in February or March because they've reached their accrual numbers. So I hope that answers the question.
Very good. We have a follow-up question from Melanie asking, is laser radiation a real thing?
So I'll
Go ahead.
Richard, do you want to address that? Actually, I was thinking of you.
Oh, so I think there's two different modalities in terms of treatment, and one is, and there's many different competing modalities that you'll hear. One is, stereotactic radiation therapy that Dr. Sean Davidson does, as well as other types of therapies. Like you hear about CyberKnife, true beam therapy, proton beam therapy, laser ablation, and they're all microwave ablation as well. Radiofrequency ablation. They're all energy technologies used to treat tumors, but there's different indications for each one. So to address specifically lasers, we do use lasers to ablate tumors, but they're usually done in a palliative fashion where we have an obstructing tumor. And Dr. Kuklaitis also probably can comment on that as well, where we use a high-powered laser to ablate tumors to relieve someone of an obstruction of an airway. And that's where we use a high energy laser beam called an ND-YAG laser. That's different than when we use what Dr. Sean did, all the other, that we can comment on in terms of using the SBRT for high generation energy towards treating it for curative intent. So the indication is a little bit different, and we use all those technologies, but each one is used for a different indication. And maybe some of the other panel members can comment on the other technologies.
Thanks, Dr. Chang. Yeah. So, in terms of the radiation, radiation's used in a lot of different presentations of lung cancer. And like Dr. Chang had said, is that one technique that we do use is stereotactic body radiotherapy or stereotactic ablative radiotherapy. It's the same approach. It's a good thing for patients, and all of it is technology driven. So these days, it's quite common that we're assessing patients if whether or not they're a stereotactic candidate because it's fewer treatments, as anywhere from 1 to 5 treatments, and so that saves patients the work of having to go to and from a cancer center for radiation treatments. And trials and research have shown that it's very effective as well. And so essentially what it involves is some high precision, high accuracy, high energy radiation to just target the lung tumors and deliver an ablative dose. And we do that certainly a lot more today than we did 5, 10, certainly 20 years ago. And it, like I said, it is very effective.
Thank you, Doctor. Kathy asked a question. What are the chances of getting lung cancer for someone who doesn't have a history of smoking?
About 15% of lung cancers in this country occur in patients who have never smoked. They don't have any other risk factors. They weren't around secondhand smoke. They don't have radon exposure or asbestos exposure. And it's very frustrating. It used to be that, and this is happening more and more in younger women. I have a slide where I used to show the Marlboro Man as the carrier, the sign for lung cancer. But now you're looking, and it's a very scary thing. We find women who have never smoked. A number of these folks do have genetic changes in their cancer. I saw there was another question about family genetics. When we talk about lung cancer genetics, we're not talking about a familial predisposition to cancer like BRCA1 in breast cancer or other types of mutations that could predispose to colon cancer like the Lynch syndrome. In lung cancer, these are very specific to the cancers themselves. They're not found in any other part of the body. And sometimes these mutations can occur. We don't know why they occur. We don't know how they occur. But when they do occur, it can set the patient up to develop the cancer. Many of the non-smoking women who develop lung cancer have tumors that can be treated with one of these new targeted therapies. So that's fortunate for us. But unfortunately, it is smoking in lung cancer in non-smoking patients is the 7th leading cause of cancer death in this country. So it is a significant problem because folks are not getting screened. They have no reason to get screened. And they're presenting with widespread disease, and it's very, very frustrating for all of us.
Wow. We do have time for one last question, and I imagine that this is on a lot of people's minds right now. What precautions are being taken to keep patients safe from COVID at LVHN, and have treatments been delayed because of it? Who'd like to take that?
I'll start.
Go ahead, Sean.
All right. So certainly COVID's real. We're definitely taking precautions for it. At the same time, we recognize that cancer does not stop for a virus, and lung cancer is very serious. We treat it very seriously. That's why you have all these panelists this evening, is that it's really a multimodal assessment, because there's a lot of different players who may get involved in a patient's treatment to optimize outcomes. So certainly in terms of COVID specific, definitely a mask, like everyone should be wearing. Hand hygiene, wearing a face shield or goggles as well. And then also timing as well in terms of patients. So if patients, at least speaking for radiation, if patients have COVID, we're definitely still treating them. Although instead of being able to offer them any time of day to treat them, we'll likely end up treating them closer towards the end of the day, so that we can do appropriate, room cleaning and all that after they leave, should there be other patients with COVID. And we've been very effective at that. That has not slowed down our, at least for radiotherapy treatments for patients, and talking with colleagues, that also goes with surgery and chemotherapy or immunotherapy administration as well. So that's a very good question, certainly in light of what's going on globally. We've adapted and seem to have continued to march forward um, without causing too much or any interruption to the care of the patients.
I would copy what Sean said. We question our patients before they come to the office. The office takes great precautions with barriers and masks. All the providers are wearing goggles and masks. I wear a double mask because I'm one of the older guys. But we have not found an increased risk of COVID in patients receiving chemotherapy in our hands, above and beyond the general population. So we've been very fortunate as well, because everybody was worried, would chemotherapy predispose somebody to get COVID? We haven't seen that. Would immunotherapy enhance the immune response to COVID and increase the risk of pneumonia and ventilators? And I don't think we've seen that either. We've been very lucky. We take great precautions in our infusion suite. As unfortunate as it is, families cannot come in. In the office, we only allow one family member with the patient, and others can listen by speakerphone or some other technique. So we are taking as many precautions. The rooms are scrubbed down after each patient and sterilized. Careful hand washing, mask wearing is really quintessential in caring for these folks. Rob, what are you doing in your office?
No, I think it echo the same comments, Elliot. I mean, I think it's we're screening patients coming in. All employees at Lehigh Valley Health Network are being screened for symptoms. We really do have sufficient masks and goggles and gowns and gloves now, and everyone is, I think we're doing a great job in terms of cleaning the room, wearing the appropriate personal protective equipment, and screening patients and staff.
I think in terms of treatment overall, a lot of people were concerned a few months ago when we had the peak of our COVID crisis. All surgeries were held, elective surgeries were held and put on hold. However, we didn't make exceptions for cancer patients because we did not consider that could wait for a few months. So we did get special exceptions to proceed ahead with lung cancer operations during the height of the COVID crisis. So the hospital prioritizes cancer patients as a priority during any circumstance. And what happened was operations such as elective hernia repairs, elective knee surgeries or shoulder surgeries, they were all put on hold. They could not be done, and we had to get special exceptions every time we did an operation, and they would clear any of the people who had cancer. And so none of the cancers surgeries were delayed due to the COVID crisis.
Very good. Thank you so much. And I'd like to thank all of our panelists once again for the great information that you shared, certainly, answering all the questions that came in. Dr. Elliot Friedman, Andrea Rivera Rodriguez, Dr. Robert Kuklitis, Dr. Sean Quinlan Davidson, and Dr. Richard Chang, and all of you for also participating tonight and attending our very first virtual lung cancer event. Please be sure to complete the survey that'll pop up on the screen when you exit the program. And I just want to mention that today happens to be the World Pancreatic Cancer Day and the Great American Smokeout. The Great American Smokeout, if you're not familiar, is to encourage people to start their journey towards becoming smoke-free as a step towards a healthier life while reducing the risk of cancer. Andrea mentioned in her slide presentation that people can call 888-402-LVHN to schedule over the phone or face-to-face counseling for tobacco cessation services. So definitely look into that if that is something that you are looking to do. And finally, everyone will be receiving a small gift in the mail As a thank you for attending, and I'll just show this now if you can see on my screen, it is the Lehigh Valley Health Network mask, which you can use and obviously add to your collection of what you're using right now. Thank you again for everyone for joining us. This, of course, has been a recorded presentation, which will be available to you again at a later time. And we really appreciate your time this evening. I'm Stephanie Wells from B104. Have a good evening.